Hi there. Thank you for tuning into this educational module from Diapharma. My name is Matt Seb. I'll be your host for today's 5-minute seminar discussing primary hemostasis and their effector, thrombocytes, also known as platelets. Now, let's say you give yourself a paper cut by accident and you start bleeding. After the general screaming and frantic hand-waving about has subsided, you may notice that there's some blood seeping out of your cut, and not much later, the blood stops. This is hemostasis in action. From the Greek "haemo," meaning blood, like hemoglobin, hematology, and stasis, meaning motionless or stopped, so literally motionless or stopped blood. In the more modern sense, hemostasis is the fairly delicate balance between bleeding and clotting. Too much clotting, there's a risk of developing a thrombus. Examples include pulmonary emboli and myocardial infarction, also known as heart attack. Not enough clotting, you have a risk of hemorrhage. Von Willebrand disease and hemophilia are two examples of bleeding conditions that can have serious and deadly consequences. Hemostasis can be divided into two main components, primary and secondary hemostasis. Today we'll talk about primary hemostasis. So, do you remember that paper cut? Yeah, of course you do. Those things hurt a lot. Once we've torn our skin and blood vessels open, blood is able to flow from inside our body to outside of our body. Almost immediately, the nerves in the area will register that a cut has occurred and will trigger the smooth muscles in the vasculature to constrict, a term called vasoconstriction. Constricting the blood vessels will have a few effects. In addition to slowing the blood down, vasoconstriction will also increase the amount of endothelial collagen, that is the glue that holds the blood vessels in place, and it exposed to the flowing blood while creating shear forces. Now, we can and do mechanically mimic vasoconstriction by applying pressure to our wounds as we occur. Remember that paper cut, you may have instinctively pushed your finger against a neighboring finger or into the palm of your hand, or you clenched it with your other hand entirely. This is vasoconstriction in action. Now, von Willebrand factor is constitutively expressed by the endothelial cells and released into the vasculature. Now, these von Willebrand factor will bind to the exposed collagen and is able to form large multimers. Self-aggregation is regulated by a protein known as Adams 13. Now, these multimers help catch passing platelets and bring them to the exposed collagen, where collagen receptors in the platelet will bind to the exposed collagen. Once bound, the platelets mobilize calcium ions, activates receptors, changes shape to include lots of pseudopodia and maximizes the surface area, and secretes its granules. Some of the molecules included in the secretion are ADP, thromboxane A2, and serotonin. Now, serotonin is a vasoconstrictor that will help maintain the narrowed vasculature. ADP will act to attract additional platelets and bind to their P2Y1 and P2Y12 receptors on additional platelets, while thromboxane A2 will bind to the TP receptor on additional platelets and assist with aggregation. Either of these will lead to activation of the additional platelet, mobilizing calcium, degranulating the platelet, and activating the GP2B3A receptors. Another key method of platelet activation is via the PAR1 receptor. This receptor binds to a portion of the thrombin that is activated by the coagulation cascade. Now, seeing as activated platelets release factors that either attract or activate additional platelets to the area, it is easy to see that platelet activity progresses in a feed-forward mechanism. Now, this GP2B3A activation allows the platelet to bind to the fibrin being generated in the coagulation cascade of the secondary hemostasis. The mesh of platelets and polymerase fibrin is what primarily constitutes the mature plug that will arrest bleeding. As I mentioned, fibrinogen binds the GP2B3A, anchoring them together, forming a platelet plug. Next, acetaminophen and the filopodia contract on the fibrin fibers, shortening the gap between platelets in a hand-over-hand mechanism. This compresses the plot against the air, allowing blood to flow past. Given their role in clotting of all sorts, including ischemic stroke, heart attacks, and venous thromboemboli, it isn't surprising that there are a number of different classes of platelet inhibitors that have been developed, several of which are very common. Leading off is aspirin. This drug irreversibly inhibits cyclooxygenase 1 from catalyzing the first reaction, which converts arachidonic acid to thromboxane A2, thereby preventing activation of platelets via this route. The next class are the thiopyrimidine class of inhibitors. This class of drug blocks the P2Y12 receptor, preventing AD binding, signaling, and aggregation. Examples are clopidogrel, also known as Plavix, ticagrelor, and Prosigel. There are also two classes of intravenously available platelet inhibitors: the GP2B3A inhibitors, which prevent the aggregation of platelets to other platelets via fibrin. Abciximab, eptifibatide, and tirofibam are all examples of this class of inhibitor. Also available are the direct thrombin inhibitors, such as argatroban, which will prevent platelet activation by removing thrombin from circulation so that this cannot bind to the PARP receptors present on the platelets. There are many different types of disorders associated with platelets. They are characterized in one of three ways: too many platelets, too few platelets, and dysfunctional platelets. The normal range of platelets is between 100,000 and 400,000 per microliter. Many platelets, thrombocythemia or thrombocytosis, is greater than 500,000 per microliter. Various myeloproliferative neoplasms can lead to this. Too few platelets, also known as thrombocytopenia, is characterized by having fewer than 100,000 platelets per microliter, and is considered severe at 50,000 per microliter. This can be genetic nature, such as in Bernard-Soulier syndrome, or acquired, for example, in heparin-induced thrombocytopenia, or via the Zika virus, or in response to chemotherapy. And for dysfunctional platelets, these can also be genetic, such as Glanzmann thrombocythemia, and also von Willebrand disease is caused not by defects in the platelets themselves, usually, but in how the platelets interact with collagen. If you remember, platelets will bond to von Willebrand factor, which is defective in von Willebrand's disease, which will bind to collagen. Thank you for tuning into this short webinar presented by Diapharma on platelets and primary hemostasis. You may be interested in learning about secondary hemostasis and the coagulation cascade, platelet function analysis, Adams 13 and von Willebrand's factor, or any of our other videos that we have made. Please visit us at www.diapharma.com. To talk with us, please send us an email at info@diapharma.com. Thank you for your time, and I hope to talk to you soon.